CDC Director, Dr. Rochelle Walensky. Doctor, thanks so much for making time for us today.
Good evening, Brett. Thanks for having me.
You've heard those two reports, and obviously there's concern about the messaging and what's coming out. I want to put up a couple of full screens first, and they were referenced in those two reports. First is breakthrough numbers. Fully vaccinated Americans, it's a real credit that 164 million plus have been vaccinated. Of those, we're told from your organization that hospitalizations are at 6,200. That's 0.0038% of fully vaccinated. And of those, deaths are at 1,263, 0.00077% fully vaccinated. So break down these numbers and the concern about the vaccinated and the changes that you're making.
Yeah, thank you for raising this. So 164 million people fully vaccinated, and that I think is a true success, and we still have a lot more work to do. I want to be very cautious about the interpretation that you just made with those 6,200 cases. The CDC monitors breakthrough infections in numerous ways, and one is through passive reporting. So the report you have up there with those 6,200 cases is passive reporting. That is when we rely on hospital systems to report breakthrough infections as they come in. We can learn a lot about them, but what we recognize is that is woeful underreporting. We actually don't get all the reports that we need. And so what we do is we bolster that with cohort studies. These are tens of thousands of people that we follow across the country, people like essential workers, like healthcare workers, long-term care facility members and residents. And so we follow those to assess the real epidemiologic way to do breakthrough infection analysis. That the passive reporting is not the best way to do so.
Understood that. So, and I saw some of the stuff you put out about Massachusetts and what you looked at in that one community. But in the internal slides from the CDC that got to the Washington Post, it appears that some of your decision was partly based on a non-peer-reviewed study from India that looked at vaccines not approved in the U.S. So I guess the question is, why are you using foreign data of non-U.S. vaccines as at least a part of a basis for your decisions here?
Yeah, let me be very clear. That was an internal briefing to me to give the comprehensive view of what was out there in the literature. The India data were not at all used to make this assessment. I had seen last Friday the data from Massachusetts that were published today, and I certainly didn't want to use one single site in order to make that assessment and to change these guidances. So what we did is we looked at other sites that were conducting outbreak analyses and discussed with some international colleagues who are ahead of us on the Delta variant to see what we could glean. And what became very clear is that the data that we saw in Massachusetts were corroborated in numerous other places, and that's when we knew we had to take action. But to be very clear, that internal briefing was not the data that we used to make the decision. In fact, the decision was made after that briefing.
All right, but you're leading with the information that the vaccines work, that they're effective, that they prevent, for the large part, hospitalizations and deaths.
Absolutely, and that remains, fortunately, to be true with the Delta variant.
So for the masks to be added to that, are the vaccinated people wearing the masks to protect the unvaccinated people, or are they protecting the vaccinated people?
The vaccinated people, so if you are vaccinated, when you are vaccinated, you are protected from severe disease and death. And when we removed the masks in May for the vaccinated people, the Alpha variant was the predominant variant. And we had data to suggest at the time that if you were infected as a breakthrough case, that you couldn't give disease. You couldn't give Alpha disease to someone else. Fast forward now, the end of July, the predominant strain here is Delta. And so what the data that we saw was actually unlike Alpha. Delta allows you to transmit to somebody else. So the masks are really being put on for vaccinated people in areas of high density disease, such that if they were to get infected, that they knew that they might bring it to somebody who is immunocompromised, somebody who was not yet vaccinated. So it was really to prevent transmission.
Right. Dr. Walensky, you can imagine people, confused by the messaging from the beginning to now, and we understand what you're saying is that the variant caused evolution of how it reacted. However, there is a feeling that the goalposts moved here a bit. Here is Dominic with a question about that.
Good evening, Brett and Dr. Walensky. This is Dominic Marcy from Vienna, Virginia, with a couple questions. If it's considered rare to get COVID-19 if you're fully vaccinated with the Delta variant, when will we ever get back to normal, when masks are not required? And my second question is, if other variants come along, at what percentage of cases of hospitalizations do you not recommend wearing masks? Thank you.
Let me just put a finer point on it. You know, we started this whole thing with trying to stop the spread, and we were going to flatten the curve to prevent hospitals from being overrun. But now it does seem, Dr. Walensky, to Dominic's point, that we are trying to kill this virus entirely. And can you just answer his percentage point question?
Yeah, thank you, Dominic. Thank you for that question. So I think it's really important to recognize that as we think about the absolute number of people who are getting infected, that is related to the number of people who have disease, the number of people who are vaccinated, and how well those vaccines work. So it is actually quantitatively possible to have 95% protection from hospitalizations and still have a lot of breakthrough infections if most of your population is vaccinated.
But is there a normalcy? I mean, is the next variant just around the corner? And is that something, you know, that we're always going to be on this stop and start with putting masks on or not?
So I want to just articulate that this was not news that I expected the American people to welcome. This weighed heavily on me to have to do this. But I will also say that this virus has been humbling. I was taking care of patients a year ago. I joined the CDC 6 months ago, and the science continues to change. And while that is neither simple nor easy to convey, it's my responsibility to keep the American people safe. And as that science evolves, I evolve with the CDC, the guidance. What I will say is I continue to be humbled by this virus. I have no interest in continuing mask guidance. And the best way to stop a new variant from spreading is to have less virus out there. And the best way to do that is to get people vaccinated and to mask up until they are.
Dr. Walensky, you said the other day that we're just 2 or 3 mutations away from a variant that can't be defeated by our vaccines. There were some former health officials, top health officials, who found that troubling and thought it was a little bit of fear-mongering because they believe that the vaccine that we have currently, the mRNA, can be adjusted to deal with whatever variant comes down the line and can be fixed within a matter of time, and a short matter of time. Is that factual?
I think both are potentially true. I said, I believe, a few mutations away. You know, the virus is smart. The virus is out to make sure that it can survive, and it is an opportunist. It will go where we are not vaccinated. The more the virus is mutating, the more it has an opportunity to mutate away from our vaccines and to be able to evade them. That, I think, is true, and that's the general concern of science. We're not there yet, and we're very lucky to not be there yet, but we have a lot of virus circulating here. It is very true, and I think it's a scientific win that we have mRNA vaccines that can be adapted for new viral variants, new mutations, and that's amazing. However, that will take some time, and so what we'd really like to do is not have to be in that place.
Last question quickly. We're going to take a break in a second, but speaking of time, when is the FDA going to authorize the full approval of vaccines that have been on emergency authorization so far? The president the other day said it's the fall, but the FDA has put out that it might be January 2022. Why is it taking so long?
You know, I don't know the FDA's timeline or plans. I will leave that squarely with the FDA. But what I do know is that the due diligence and the science and the review and the epidemiologic data need to be done, and the FDA is working hard to do so.